Dr. de Oliveira. What's your clinical background and expertise?
I'm a professor of psychiatry and psychopharmacology at the Department of Psychiatry in Salvador, Brazil.
What can you tell us about the integration of psychotherapy with psychopharmacology?
Yeah, it's a very interesting question because in the beginning I used only psychopharmacology. But I felt that there was something missing. Sometimes we have to wait for the drug to act, and you just give a support to the patient. But when you have something, an expertise in psychotherapy, you can add something that is very important. In many disorders, psychopharmacology, the drugs and psychotherapy, it's known that they work better together than just one and the other isolated. So that's what I've been doing in the last few years, using both. Sometimes just psychopharmacology for some patients, sometimes just psychotherapy, and sometimes both. It depends on the disorder.
What can you tell us about your work in trial-based cognitive therapy?
Trial-based cognitive therapy is an approach I developed 5 or 6 years ago, and I started to use it in several disorders in psychiatry. In fact, it is cognitive therapy, standard cognitive therapy, but it is different in the way we use with the patient. For example, it is much easier for the patient to understand because I use a lot of metaphors. For example, the metaphor of the law. So, for example, the patient can role-play a prosecutor, a defense attorney, or a witness, and it is different from cognitive therapy in the way we do at the same time restructuring and an experiential approach. For example, we use a lot of what is known as empty chair. For example, the patient can sit in a chair and imagine that he is in the other chair. We call this empty chair. And for example, he will say, he'll look at the other chair and say, this person is a failure because he has done this or that. It's much easier for the patient to talk about himself in the third person than just talking about himself. So this is the way we do trial-based cognitive therapy, and the way it was designed is to work with what we call core belief. For example, is the belief the patient has about himself or herself. For example, I'm a failure, I'm vulnerable, I'm no good. And the patient has to prove in the beginning that this is true. But in fact, in almost 100% of the cases, he doesn't get to, he will not succeed to be considered guilty. So always not guilty.
Compared to standard cognitive therapy treatment, what are the results of your technique?
I have a clinical trial that has been published comparing standard cognitive therapy and the trial in social phobic patients. So, in fact, regarding the fear of negative evaluation, the trial-based therapy was superior to the standard cognitive therapy. Both worked, but I was very surprised with this result. Summarizing, trial-based therapy is CBT, but it is different because it is much easier for the therapist to learn it and much easier for the patient to engage in this process. And at the same time, we are we are changing the cognitions, and it is very experiential at the same time. So this is what we have added to standard cognitive therapy.